During this episode of Banner Health's Making the Rounds podcast, we will be discussing RSV, Respiratory Syncytial Virus, and the management and treatment of this respiratory illness. Making the Rounds dives into medical topics with those who know them best, healthcare providers. My name is Bridget, and I'll be your host for today's episode. If you're new to our podcast, thank you for tuning in, and if you're a regular listener, welcome back. With me today are Dr. Chan Lowe, Division Chief of Pediatric Hospital Medicine at Banner University Medical Center Tucson, and Dr. Melissa Zukowski, Medical Director, Pediatric Emergency Department at Banner University Medical Center Tucson. Thank you both for joining me today.
Thanks for having us, Bridget. Happy to be here.
Thank you.
Well, thank you for taking your time and discussing this very relevant topic with us. We're still treating cases of COVID, and with the fall season comes the flu virus, and now we're seeing an increase in RSV cases. RSV, Respiratory Syncytial Virus, is a highly contagious yet very common seasonal respiratory virus. It's a common childhood illness that can affect adults as well, especially those who have a compromised immune system. Most cases are mild, with cold-like symptoms, but severe infections can lead to pneumonia and bronchiolitis, which can require acute care and hospitalization. Since we're starting to see an increase in RSV cases, Dr. Zukowski, can you share with us when a patient should be referred to the hospital for emergency care, and does the criteria differ based on the patient's age?
Absolutely, Bridget. Thank you again for having me today. The biggest thing that we want to think about with RSV is really how the child is handling the virus. RSV is something that we've seen year over year. Interestingly, with COVID, we haven't seen that so much in the last couple of years. So we're seeing a lot more kids that are being exposed to it and getting ill from RSV because they didn't have that exposure over the last couple of years. This is something that absolutely majority of the time looks like a common cold virus and can be managed at home and with your local pediatrician. However, where we want patients to come into the emergency room is if they're having signs of respiratory distress, they're breathing hard, they're working hard, and especially keeping an eye on those patients that are younger. The younger the child, some of our neonates, our babies, don't handle the secretions and the nasal congestion that RSV will bring, as well as an older child or an adult would. So really making sure that we can suction them, that we can help them breathe well on their own and they're handling it, that makes us much more comfortable that that child will be okay at home.
When we look at the symptoms of RSV in babies and toddlers and older children, what are some of those symptoms that we should look for when we're discussing hospitalization?
So some of the most common symptoms that we'll see are nasal congestion, increased secretions, and other things like other common cold viruses like cough. Where we worry about children is if they're having that difficulty breathing or they can't control those secretions or clear their nose out to help them breathe. And so again, in that smaller age patient, someone under 2, for instance, is where we see them impacted the most. We want to make sure that they have that ability to have saline, to have suction, to have those things to help them breathe. And if the parents are having trouble at home overcoming some of those symptoms, that's when we need them to follow up first with their pediatrician. But if they're having signs of respiratory distress or difficulty breathing, working hard, the little muscles between their ribs are really pulling, or what we call retractions, those are reasons we'd want them to seek a higher level of care if all the things at home from the supportive care standpoint aren't going the way they should. In an older kid, it may be that they have a cough for a week or 2 weeks, and it can be nagging and really annoying. But really, it's just working through that again, humidifiers, supportive care to work through it, and recognizing that it is something that will last a while. It's more annoying than anything, to be honest, is that it lingers. But the older child, for the most part, is going to do just fine, as will an adult, unless you're someone who has a weakened immune system.
How should a primary care determine when a patient should be admitted and sent to the hospital versus sending them home with home care?
So I think a trial, if they look good in the clinical office, I think sending them home with a trial of home care is okay. I think if the tools that the parent has at home for the younger child with suctioning and humidification and those sorts of things aren't working, then that might be reason to send them in for evaluation to the emergency department or that close outpatient follow-up with the pediatrician. If it's someone who has an underlying chronic lung disease, a history of asthma where they may be triggered by this virus more commonly, and they're on their asthma action plan, let's say, and it's just not working. They're needing their nebulizers more often than normal. They're not making it to the every 4. We talk about every 4-hour albuterol oftentimes in our respiratory patients. If they're not making it to those treatments and they're needing them more often, then that's when they probably need to come in to see me and my team and may potentially need to be admitted to Dr. Lowe's team.
Dr. Lowe, what is the recommended treatment for patients with severe RSV?
It's really primarily supportive care, even still after they're sick enough to be admitted to the hospital. We focus really on giving them oxygen if their oxygen saturations are low, and suctioning their nose. A lot of the other things that traditionally we've done that we like to sort of try because we feel the need to do something, it really just don't work. Things like albuterol nebulizations. There was some push to do hypertonic saline for a little while. Racemic epinephrine, there's a little bit of evidence to support that, but even that, it's still not a great treatment. By and large, the only thing that works is giving them oxygen if they're hypoxemic, and if suctioning out their nose to try to keep their airway open the best we can. The littler kids sometimes will have more severe difficulty with that, and that has to do with their smaller airways, and that if we go way back to medical school physiology, of that resistance in the airway is proportional to the radius to the fourth power. So those small changes in an already small airway from a little bit of inflammation or mucus then leads to significant increase in resistance. Those kids can have a little bit of trouble, and there are some things we can do to help that. Things along the lines of high flow nasal cannula to give a little bit more respiratory pressure to help them get a little bit better breath, all the way up to needing to transfer to the ICU for more formal pressure type support, things like CPAP, BiPAP, and ultimately intubation if needed.
As the medical professionals, when do you identify when the patient is ready for discharge, or when would they go to the ICU and be transferred to that critical care?
In terms of the discharge criteria, the biggest thing that keeps kids in the hospital is need for oxygen. And so they'll stay on oxygen. Our average length of stay for typical bronchiolitis is somewhere around 2 to 2.5 days. Typically, by that point, they've been able to be weaned back to room air and they do well. But the hypoxia can continue for 3 to 4 weeks, even with bronchiolitis. And so there are times where if the patient otherwise looks good, is eating well, breathing comfortably, but just so has a persistent oxygen requirement, we may opt to send them home on oxygen for a week or two. If that happens, then there are a couple strategies we can use. One is to have them come to the primary care physician's office, and they can turn the oxygen off and do an oximetry saturation in the office to see if the saturations are now high enough. And if the provider for inability to do that or uncomfort with doing that is unable to see the patient, we certainly can get them set up to see our pulmonologist to help wean that oxygen as well. In regards to the need to transfer for ICU, that's often driven by work of breathing. And as the child just continues to have increasing work of breathing to the point where their blood gases are starting to look problematic, their carbon dioxide levels are starting to climb, then it's time for us to intervene with something a little bit more significant than we can possibly do on the floor, and we would transfer to the ICU for one of the increased pressure support therapies.
Most of our listeners are familiar with the antibody treatments for the COVID virus, but is there an antibody treatment for patients with RSV? Can you tell us a little bit more about this treatment, and are there specific qualifications or criteria?
So we've had, not new, but we've had the longstanding Synagis treatment, which is palivizumab, and that is a series of monthly injections that high-risk infants will get. And those patients who get that to qualify typically need to be premature, have a cardiac disorder that puts them at high risk, or some other type of disease like a neuromuscular disease that puts them at high risk. And that typically is really more of a preventative measure. It doesn't do much for them once they get RSV. There's a newer antibody that is looking good in studies, and it sounds like it's going to be hopefully submitted soon for FDA approval. That would be a one-time shot, very similar to palivizumab, where they would get that, the infants would get the shot at the beginning of the season and try to protect them throughout the season to keep them from getting it. Once they get RSV, I'm not aware of any antibody therapy for RSV specifically at this point, like there is for COVID.
Being that it's not just RSV season, it's not just flu season, we're still dealing with the COVID virus. What happens if a patient is is positive for all three of those viruses? How are we handling those patients that come in?
Yeah, so we would still handle them when they come in the same way, but we may see that they're a sicker presentation, be it a smaller child or even into an adult. So we had some patients, even historically when COVID was higher, that would have COVID plus influenza. Those might be patients that did require that hospitalization. Oftentimes, in the emergency department and in the inpatient setting, we do test for all of those different viruses because we have that capability. But really, at the end of the day, less so for what they're positive for, but more so managing them and helping them through their symptoms is what we care the most about at the end of the day. We're definitely seeing RSV coming. We hadn't seen it in the past couple of years because of COVID. We're definitely seeing it coming. We worry that it may be worse as we get into these winter months. That would be normal for history too. But what we're most concerned about is making sure that they're supported again with that supportive care at home or with their primary care physician, and then most importantly, as Dr. Lowe had alluded to, making sure their oxygen saturation and their work of breathing are appropriate. So whether they have one or three, it would just all depend on what that patient looks like in front of us at that time, and then kind of what interventions that they need to kind of help them through that natural disease course. If one of our local pediatricians, needs to reach us at any point in time, if they're concerned about a patient that they have in front of them in the office, they absolutely should call and contact Dr. Lowe's team or my team in the emergency department through Banner Health Transfer Services. That is our system-wide transfer process. If it's someone that, while they're speaking with Dr. Lowe, he thinks that they need a direct admission, they will work through that process together. Sometimes when you call, it may be that we're not quite sure, is it a patient that's appropriate for the ICU or the floor, and there's a little bit more of a gray zone. Then sometimes my inpatient colleagues may defer you to start with our pediatric emergency colleagues first, to get things started, get an evaluation, and to determine which way they go from there. Dr. Lowe, do you want to review maybe for our listeners how our patients with bronchiolitis do in the long run, whether they start with you on the pediatric hospital service or the ICU, and what some of their outcomes are from there?
Great. Yeah, definitely. The good news is this is a disease that ultimately the patients do well with. It's important, I think, for our families to know that it's very, very common, particularly with RSV, for infants to continue to cough for 3 or 4 weeks. Giving that information, and our team will certainly will pass that information on to them as well, helps the family to not be as concerned when they're still coughing 2 weeks from now, but otherwise doing well. But by and large, the fatality rate from RSV is exceedingly low. Even patients who go to the ICU and even those who end up being intubated, the typical course is that they do quite well. They get extubated, they come out of the ICU, they come out of my unit and are able to be discharged home without any kind of long-standing consequences from that. Certainly they'll need to follow up with their primary care physicians to be able to make sure that they're continuing to do well, but as a rule, we expect these patients to get better and go home.
I can't thank you both enough for taking the time to speak with me today and educating us on the management and treatment of RSV in an acute care setting.
Thanks for having us, Bridget.
Yeah, thank you.
To learn more about Banner Health Emergency Services, please visit us at emergencycare.bannerhealth.com. Thank you for listening, and we'll see you next time on Making the Rounds.